there are no really significant esophageal varices. There is some evidence of scarring, so I suspect he had some band ligation done. We don't have his complete records, but you'll see the scarring in the esophagus, so he probably had some band ligation done. But there are no varices that I see at this time. Now we're coming down to the cardia, so there are really no junctional varices. This is important for the classification of his varices. So no junctional varices, no esophageal varices. And now we're going to go into retroflexion, and we're going to give some CO2 and blow up the fundus and take a look. Now you already see this large convolute that's starting to protrude toward us. And it is large. In fact, it's scary. Right? I mean, if this were to bleed, I'm actually surprised that he survived his last bleed. Because this is under very high pressure. You're looking at the tip of the iceberg. So there's a large convolute of gastrorenal collaterals behind this. You might even, wonder whether this is a bit at the margin of what we can accomplish. But let's look at it with the EUS, okay? So we don't see any other varices, no ectopic varices. Now, our star anesthesiologist, the Rose, is already starting to cringe. He's already opening up all his drawers for, extra support here if the patient starts to massively. What I can tell you, though, is that if you were to try to treat these with the conventional endoscopy-guided method, you may not complete your procedure because you would probably get a waterfall of blood spurting out after you puncture this from the stomach lumen. And I really understand why your anesthesiologist, is checking to make sure that he's paid the premiums for his liability insurance and so forth. But I think if we do it EUS-guided, and we're going to try to do this transesophageal rather than transgastric, I think we could actually accomplish this. But let's see. We are going to insert our echo endoscope. And she gave me the, is this the therapeutic one? Yeah, which is fine. And we have probably more therapeutics than we do diagnostic because we do a ton of transluminal drainage. Now, I'm in the stomach, and what we're going to do is put some water now. Now, this is where the water jet with the forward view would have been very nice, right? So then we automatically just step on the pedal and we can fill the lumen up. Here, we have to ask Kate to do a little work, give me the syringe, fill this up, get another syringe ready, and we're going to fill the fundus with water, and I'm going to suck out some of the air too, make it easier. But the good news is that the water preferentially goes to the fundus. That's not always a good news when you're trying to look at a submucosal lesion in the antrum, for example. But here, it's good news. Now, on EUS, I don't even think I have to show you what you're looking at. I think everyone sees it. These are gigantic. They've got lots of vigorous flow. And it just kind of goes everywhere. Back here, there's a splenic hilum. These are massive. Massive, all right? Let's just measure this out. Now, these are the gastrorenal shunts. We're not putting coils and glue into this. But look at these shunts. This is huge. This is 2.3. Now, this is not widely available in the US, but if I were consulted on this case and it were available, I would consider the option of BRTO. So this is the balloon retrograde obliteration done by the radiologists because they can actually target these gastrorenal shunts quite nicely. I'm actually surprised, though, that the radiologists didn't really get their coils here because I don't see the coils here, right? I mean, I will look for them. I'm wondering, you saw the coils on the CT scan very nicely. They were very prominent. But I don't see them and I should see them with EUS because it's metal. It should be very bright, but I don't see them. So where are those coils that the radiologist placed? Maybe here. There's something that seems to shadow a little bit there. Maybe if you look here. All right. So regardless, I think we can treat this here. This is intramural. This here is extramural. We don't want to touch this. If you try to put a coil in here, it'll swim away. So our coil is the largest coil we have, has a diameter of 2 centimeters. In fact, I wonder when the radiologists do their treatment, because we're actually using the same coils that the radiologists use, what would a radiologist put in something like this? The largest size is 2 centimeter diameter. So you look at the diameter of the coil and you look at the length of the coil. Now the length of the coil also goes up to, I think, 2 centimeters. And what the length determines is how many loops you get. So the length is how many loops form. The diameter is diameter, right? The diameter of the loop. If you have a varix that is 10 millimeters, well, you don't want to put in a 7 millimeter coil, right? Because it'll flow away. So you want to use a larger diameter. So you customize the diameter to the size of the vessel that you're treating. Makes sense. All right, so we don't want to touch this here. We want to go here. Now the question is, can we do this transesophageal? What does that mean, transesophageal? Well, that means we're going from the esophagus, and this is the Crus muscle, and the fundus is somewhere down here, but we don't even, normally we see the fundus here, normally, right? Because it runs parallel to the distal esophagus. Normally, I would show you the fundus, but we don't see the fundus. Why? Because they're huge gastrorenal shunts here, gigantic, and we don't want to treat those. So to go transesophageal means we would have to go through the gastrorenal shunts to get to where the fundus is, which is down here. The fundus has been displaced because of these huge gastrorenal shunts. So that's actually not an option. Now, I prefer to go transesophageal if I can, but I can't. This is not an option for this patient. All right, so now we come back to these guys, and I can treat these, but I'm going to be doing it transcardia. It's not transesophageal. It's not really gastric or so, because I'm still high up there. I'm not coming in my normal retroflex position that we would use if we did this endoscopy guided. But it's not ideal because I always prefer to go transesophageal, transcrural if I can. Let's get our FNA needle now, 19 gauge. And there's no feeder vessel that I can identify here where I could say, look, if we hit this feeder vessel, maybe this guy here down at the bottom. But I think in this case, we just stay focused on the intramural varices that we see. So our 19 gauge needle, standard FNA needle. And what we've done is we've primed it. We've primed it with saline. Okay, so the stylet is out. It's been primed with saline. And why is that? Because we do not want to inject any air accidentally into the varix once we puncture it. We want to make sure that we don't contaminate it with any air. We should always have fluid in there, whether it be our saline, flesh, or blood. All right, so now we're going to bring the thumb screw down, and I don't know whether there's a camera that can show this. I don't know what they're looking at here, but I'm going to advance. This is just like what you saw before with the Axios. Now, one thing I can tell you about a 19 gauge is with a plastic sheath, unlike a coil sheath. So a plastic sheath will stick against the elevator. It won't negotiate the elevator at times. And if you encounter resistance advancing your needle, do not force it, because you will puncture your working channel. So you got to go back, and you've got to advance your sheath forward. In fact, it's probably a good practice to always advance your sheath first. But it's actually not necessary when you use a coil sheath. And that's why I like coil sheaths. But this doesn't come with a coil sheath, only a plastic sheath. All right, so now I'm going to advance this now. And you can see the needle at the top, right? It's local echogenic. And now I'm ready to puncture into right here. I'm just going to go right into this guy here. I'm in. You can see it. And we're going to aspirate. So if I have our camera looking at this, please aspirate. You can see there's blood flow. No surprise. And now we're going to flush it. So we're flushing the needle free of blood because we don't really want blood in there. Some will come back, but we want to minimize that. Why is that? Because we're going to put the coil in, and the blood is going to increase the resistance as we advance our coil. So we have attached the introducer, it's a lure lock, to the end of our FNA needle, right, where normally the stylet goes. So it's lure locked on here, and we are advancing the coil into the FNA needle. Now, once the FNA needle, once the coil is advanced into the FNA needle, we can remove the introducer. We don't need it anymore. It's easier. And now the assistant is advancing the stylet, using it as a pusher to push the coil out of the needle. And I'm going to pull back as the coil comes out. And I might even direct where I want my coil to go. In fact, I'd like my coil to maybe start down here. I'm going to try to maximize. You know, this is like a roller coaster here. So these are like septae, but they communicate. So I'm going to see what the coil does when it starts to come out. And that's okay if I just place it here, but maybe I can get it to go in the lower half. I probably would rather it go into the lower half, but let's see if I can do that or find a way to get it there. It's kind of, there's like a septum or a fold there. All right, let's just put the coil out because we don't want to waste too much time. Otherwise, it'll get really sticky. It's pushing out. You see it. It's beautiful. Very echogenic. There's no problem seeing these coils. There's coil number one. Now, because these are so big, I'm going to have our assistant insert a second. We're going to first flush the needle very carefully. And while she's getting ready, I'm going to go down here to deeper level. See there. All right, now I'm going to put another coil down here. Okay, so same protocol here, same steps. We flushed it, right? Now it's coming, flushing. You see the air bubbles coming, not air bubbles, but the water. It's actually a little bit of air in the H2O. There is an O in the H2O, so that's what you're seeing. And now we are attaching, lure locking our introducer. That introducer comes with a kit, so this is nothing that special. Comes in the kit that the radiologists use. And we have introduced the coil now into the FNA needle. No need for the introducer. Now we are advancing the stylet. And we'll, once again, wait for the coil to come out. So all of this is very controlled. It's under vision. And this is why those of us who are accustomed to using EUS always feel more comfortable when we can see what's going on versus doing it blindly, just endoscopically. Okay, you see the coil unraveling. Very nice. Now, these coils have synthetic strands wrapped on the coil. It's an alloy. And now we're ready to start injecting the glue. So we got 2 coils in there, and we're going to inject the glue. The idea here is our coils serve as a scaffold to hold the glue in place to prevent it from flowing away and embolizing. After all, given the large size of these varices, we really want to minimize the risk of embolization. That risk is significant. We're using Dermabond, which is 2-octyl cyanoacrylate. It has a longer alkyl chain, and as a result of that longer alkyl chain, the polymerization time is much longer, which is a desired thing, a good thing from my standpoint, because it gives us more time to inject the glue in. So we're injecting it over some 30 to 45 seconds. And as the glue literally drips in there. The issue I have with using histoacryl or the N-butyl-2 cyanoacrylate is that you have to inject it so quickly that you have a very high velocity as it's going in. And you may actually, I think, increase the risk of embolization. If you let it just drip in, then I think it decreases that risk. This is all anecdotal and hypothetical, never proven. But in the end, we're called gut doctors for a reason, right? Because we use our gut. It's got to make gut sense. It's got to make sense to us when we do this. So we love the evidence when we have it, but when we don't, we rely on our gut. All right, so the glue is dripping in there, and as it does, you see how it's getting all echogenic, and it's plugging up the lumen.
I'm doing it a little slower.
And it looks... So Kate just mentioned to me that she's doing it a little bit slower. We have a 19 gauge. It's we don't have to worry about the glue clogging the needle. You could not do this with N-butyl-2. You'd have to press it you have to push it very hard, or you have to dilute it with a substance like Lipiodol, so some agent that will slow down the polymerization. So Lipiodol is used actually because it's a contrast agent, and this in the early days was done under fluoroscopic guidance, right, with concomitant fluoroscopic. And why was that? Because of the concern for embolization, that number one. But remember, this all evolved from radiology. So Nipsahendra is the first to describe the use of glue to treat gastric varices. That was back in 1987. He was not the first to use glue to treat gastric varices. That was being used by the radiologists for some time. Please, again. And Nipsahendra, though, his genius is that he observed the radiologists and everything they did, and then he very cleverly adapted those things that he thought would work for endoscopic treatment. So he is the first to describe this treatment, of course, but he's also the first to do biliary stent drainage, watching the radiologists place percutaneous drains, and he's the first to start using the glide wires, hydrophilic coated wires, which radiologists were using routinely. So these are all, we've benefited hugely from the prior experience of the radiologists. So ironically, we've put the radiologists who we've learned from, and we have to thank that we're able to do all of these things today. We've put them out of business. So that's a big thanks to them, isn't it? But it's for the best for our patients. And of course, the radiologists have moved on to other things. All right, so I'm going to remove now.
No.
Okay.
I've given 3.
3, yes.
Do you want a 4th?
Go ahead and give a 4th. I'm putting a lot of glue in today because these are so big. We usually don't. Usually it's 1 coil, 1 glue. But I'm going to just fill this up with a 4th. So these are aliquots of really about 0.5 cc's. And so, in total, it's maybe about 2 cc's that goes in. I'm just talking because, there's not much to say in terms of what we're doing right now. We're just keeping our view of the ultrasound image, watching the glue go in, watching it spread. And your risk of embolization now progressively decreases because the glue itself is acting as a scaffold for the next injection of glue. So the risk decreases as you do further injections. So once it's really that first injection of glue that's the concern. That's where you have the highest risk of embolization. And that's really why, in my opinion, it's so important to place the coil first before you inject the glue. Because otherwise that stuff just streams right away. And I know that because I used to do this under fluoroscopic guidance in the early days when Nipsahendra developed this, and I worked with Nipsahendra in the 1990s when he pioneered all of this. All right, so we've got our injection in. We're flushing the needle. So we're flushing out the glue from the dead space. and I'm going to retract as soon as all of the dead space is out, which is about a cc, right, in the dead space, correct? So after we've had a cc, I can start retracting. You see me retracting, the needle comes back. Now I advance the sheath forward as a precaution, just to make sure that I don't have a risk of contaminating my needle. Now the glue's all in the varix. I don't think it's spilling out into the esophageal lumen or the stomach lumen. I'm going to pull out now. I'm not pulling this through the working channel because these scopes are expensive. So we don't want to take any risk, even though I think it is negligible, that we could contaminate or we could spill glue into the working channel. So what the nurse is doing now is once I'm out, the nurse cleans off the tip of the sheath, the FNA needle sheath, and then pulls it out. All right. At this point, what we can do are one of two things. Let me just quickly look again, but you need to wait about 5 minutes for the complete polymerization. So it only makes sense to go down and palpate these to make sure, to confirm that they're hard on instrumental palpation, endoscopic, if you wait 5 minutes. What we can do, though, is we can look with EUS, and we can just sort of see if there are any big guys that we want to additionally inject. And maybe there are. Let's take a look. Remember, we only want to get the varices that are intramural. You see the coils here inside. This is what previously you saw those big lakes. There are no big lakes anymore. This is the intramural. Now these guys, well, they're still there. We want to stay away from this. And look, there's a little bit of something fluttering there. You see, that's how easy, it's like just kind of hanging there. So you have to have a lot of respect, and it's hanging on the coil. So you have to have a lot of respect for what can happen when you inject glue into a vascular system where there's vigorous flow, as there is in these varices, and when they're so large. I mean, it's sort of like injecting into the IVC or something when they get this big. It looks, I think, pretty good, and I don't really see anything that I need to go. I mean, this little pockets here, this will, even here, look, there's no flow, right? It looks a little hypoechoic, anechoic. There's no flow. Why? Because I've occluded everything. There's nothing feeding this pocket, and that'll thrombose. So I think this is a really nice result. It looks great. You don't see the varices anymore. And now, just for the fun of it, we can go down with the gastroscope and confirm that things are starting to harden, the varices. In other words, a sign that the varices are plugged up with the glue and coil. So the teaching point is identify patients with large gastrorenal collaterals, because those are much higher risk, and maybe even consider a multidisciplinary discussion whether BRTO might be a better option, because the Japanese literature has reported very nice results for these large gastrorenal shunts using BRTO. So that's the one teaching point here. If you do embark on this, then limit your treatment to just the intramural varices. Don't go outside, because you're inviting disaster potentially, and embolization and so forth. And you got to use your largest coils, and you need to put a lot of glue in. So now I'm going to go into retroflexion. Now, what is the amazing thing is there's virtually not a drop of blood. Of course, there's got to be a drop of blood where I punctured. So that might be what you're looking at here. I can't avoid that because I did not go transesophageal. But I'm even going to wash that off for you. See? Look at that. I washed it off. And if I had done that secretly before coming on screen, I could have said, there's not a drop of blood. Well, there's one right there. Okay, so enough of the cosmetics here, the Hollywood. You guys are down in the Hollywood area, so I've got to, of course, you know, act like, you know, as they say, do in Rome as Romans do, and so I, you know, do in Hollywood as Hollywooders do. Let's palpate this. Although actually you're kind of in a different territory. That'd be more Simon Lowe's district. I don't know if Simon's still there. I saw him on the program. If Simon is there, my warmest to Simon. He's my alter ego down there. We're kind of like twins, right? The one twin went up here and the other stayed down in Southern California. I used to be down there too, but, you know, figured you don't need two Simon Lowe's in Southern California. All right, now let's sort of see. Yeah. Now, I'm not going to be really aggressive here because he's got portal hypertension, portal hypertensive gastritis, but this is hard. I didn't show you that beforehand, but those of you that have done this know when you palpate these things, these varices, before treatment, I mean, you just sink right into them. Now, this one's softer. This one is softer, okay? But this will thrombose. And it might be that one area that I showed you with EUS where it was not completely obliterated. I can't really get at the one up there. So this is just, but this is nice and hard. See, this one, look, it's hard. So I'm happy, no bleeding. We're going to bring this fellow back, this 50-year-old patient who's been through a lot. And I honestly think if we have prevented him from another potentially fatal gastric variceal bleed, we have done him a huge service because everything that he's had done so far, colectomy for colon cancer, liver transplantation, biliary drainage procedures, percutaneous drains. He's got percutaneous drains now in place. Too bad he didn't get referred to us to potentially avoid that. All of that is for nothing if he bleeds from a gastric varix and dies. Right? All right, thank you very much.